Hi, this is Dr. Alice Lee. Welcome to iCubed. This is EMN's latest blog, and I'm so happy you've joined me. This is a blog intended for a clinician. After all, most emergency physicians are clinicians and not academics. So hopefully we'll go through a case each month and learn through it. And each month I'll have a guest, and usually it's going to be somebody I work with. And so let's get started. Nick, why don't you introduce yourself?
My name's Nicholas Vasquez. I'm an emergency physician for about 12 years.
Where did you train?
I trained at Yale New Haven Hospital. Did a 4-year residency of all things.
Yeah, so did I.
Yeah.
Uh-huh. Mm-hmm.
That 4th year, it was alternatively fun and a little too long.
Yes, that's kind of like the last month of pregnancy.
Yeah, well, I'm going to have to take your word on that one.
Yep. And have you had worn different hats in your career?
I've worn a lot of different hats. I've had one angle of my career that's been mostly about advocacy and health policy. Another angle of my career that's been in administration. I just finished about a 2.5-year run as medical director. I have a degree in healthcare management.
Wow.
But it is, at the end of the day, it is the medicine that I find the most interesting and the most rewarding.
So let's just jump into this case. She's 55 and she's morbidly obese, like many people are. She comes in with the bilateral lower abdominal pain. It's been ongoing for maybe 3 weeks or so. She does have a history of diverticulitis. She's not taking any pain meds, chronically or for this. And incidentally, she says that she's been hoarse for about 6 months now, ever since her tonsillectomy. She comes into the ER that day complaining that she's been vomiting, she's having diarrhea 3 to 4 times a day, she's got a little dysuria and a review of symptoms. But she has no fever, she's not short of breath, not coughing, no chest pain. Then looking at her chart, look at her past medical history. She's got some MRSA history. She's got arthritis, and we talked about the diverticulitis already. She has a surgical history. She mentioned already that tonsillectomy about 6 months ago. She's had a knee replacement, back surgeries, abdominal hysterectomy, and tubal ligation. So those abdominal surgeries we always kind of pay attention to in someone who comes in with abdominal pain, obviously. Looking at her meds, she's on some hypertensive meds. She's got some stomach meds, but really
Nothing standing out.
Nothing exactly. So she's not a drinker, doesn't do drugs, and she does smoke. Vital signs, she's got a normal temp, she's afebrile. Blood pressure's, okay, 125/94. She's a little bit tacky, just a little bit, so it kind of perks up your attention a little bit. She's her respirations are 24, slightly up. Sats are 88% on room air. Right, so this is a lady who's not on O2. She is a smoker, so I guess it's possibly undiagnosed COPD or something like that, And then we obviously put her on a little bit of oxygen once she came in. Everybody has oxygen when they come to the ER, whether you need it or not. So she's satting very well. Taking a look at her general appearance, she's alert, she's in a little bit of distress. We already said she's a morbidly obese lady. She's sitting up and she's a little bit uncomfortable, but not in dire straits or anything like that. Examine her skin, look at her head, her neck. All of that looks pretty unremarkable, no retractions. Look in her mouth, there's no drooling, she's not stridorous, but she does have a very hoarse voice. You know that right away as you're talking to her.
In my practice, what I've really come to value is those first 5 minutes when I walk into the room and observe the patient. Those first 5 minutes are more instructive to me and really start to change my probabilities in my head than any other piece I write or read.
So far, the clinical appearance worries you and it worries me.
Yes.
Right? You've got a picture in your head. This is a lady who's in some distress. She's a little bit hypoxic. She comes in with abdominal pain. How do you kind of put those two together?
Well, hypoxic plus abdominal pain equals pneumonia in my mind until proven otherwise.
Right.
And she's at risk for it, being morbidly obese.
Right.
You could have a pleural effusion. Maybe this is an early presentation for colon cancer resulting in a pleural effusion.
Right.
Maybe maybe she's got some other condition like cardiac disease or pulmonary hypertension.
Correct.
Right. You have a lot of possibilities being in her 50s and morbidly obese. Poor habits or poor luck, whichever you like. Right. She's got high cholesterol. She's got a couple of other things ongoing that you know of.
Right. We do see that the patient is in some distress. Her rest of her physical exam is really not that remarkable. Her abdominal exam, she's mildly tender, both a quadrant, but there's no rebound, there's no guarding. It's not a surgical abdomen. Okay. Continuing with her physical exam, she's alert. She's actually very chatty and pleasant. Nice lady. She's talking really fast.
So she's not perceiving that she has hypoxia or distress? She doesn't feel short of breath?
Nope. She looks okay, she's stable, she's talking, chatty, she's difficult to understand because she's hoarse, her voice is like this.
And you said in the beginning of the story that this had been ongoing for several weeks.
6 months.
6 months.
Of hoarseness. She had a tonsillectomy.
Okay.
So, when you talk about that first 5 minutes, you have this, or less, you kind of walk in, you introduce yourself, you notice things, but in a situation where we're presenting a case, it has to be presented sort of in time, mentally.
Yeah.
So, but in real life, you're looking at a lady, she's looking okay, and she all of a sudden she's talking to you, and she's hoarse like this, and you just go, oh, okay, well, by the way, your voice is hoarse. Is that new or is that? And she tells me it was since her tonsillectomy 6 months ago. So I'm like, okay. Back to the neuro exam, she it's hard to understand what exactly she's saying because she's hoarse, right?
Okay.
All right. So, what are you thinking? Yeah.
Well, I was always taught Occam's razor, right? And all things being equal, the single most likely explanation is the answer. But I've worked long enough at Baywood to know that multiple things can be occurring with elderly patients at the same time.
Right. Yeah. Now you got to remember, she's not really elderly. She's 55.
So I'm wondering if the sore throat and the hoarse voice has anything to do with her other problems. I'm definitely focused on the hypoxia.
Yeah.
I'm a little confused about the presence of hypoxia plus the lower abdominal pain in a morbidly obese patient.
Right.
It makes me wonder about the possibility for 3 different events, but immediately I know I'm getting labs, I know I'm supplementing oxygen, at the very least a chest x-ray, and I have a hard time seeing how we're going to get through this case without a CT.
Right. So in this case, I went ahead and ordered your standard CBC, CMP-UA, abdominal
but you
CT.
Focused on the belly, and the funny thing is in the retelling of it, I'm really concerned for the possibility of pneumonia versus PE, and wonder, perhaps I'm overthinking my most recent board testing, but seeing the abdominal pain almost as the red herring.
Well, we'll see. We'll just proceed through the case, because at the time the lady comes in, you look at the chart, she's here with abdominal pain. You notice a few things about her general physical exam. You're going through your evaluation systematically, but you're thinking all sorts of things. They're popping all over the place, obviously. And you're right to think about, well, she's a little hypoxic, and she's got a little bit of, hoarse voice. I don't know what's going on there.
Yeah.
What's going on with her belly? She's here for the belly pain. So I evaluate her for her belly pain, ostensibly, even though I also, like you do, I also kept those other factors in mind, because I have to be able to put it all together. They all have to make sense, So I ordered the CAT scan, get a chest x-ray, give her a little medication to help her. Okay? So, we're busy. This ER is situated in a retirement community. We're getting slammed with patients all over the place. So
you've painted a picture of someone who's not so sick that they need to be put in the ICU,
right? Not
so well that they can go home with prescriptions. They need that further workup to better define what their risk is, which means we sit on them for about 4 or 5 hours
for a little while.
We wait for the stuff to work out.
Since you work with me and in this ER, this lady was in the orange zone.
Oh boy.
So the first time of encounter with her was at 1817. Okay. So it's 6 o'clock in the evening, it's busy, it's a prime time. Then we're going along,
Was she on monitor?
She was on a monitor in one of those rooms that had monitors. So it was 18, 17. We're going along, and I'm taking care of this and that. Respiratory tech calls me at 19:20. Dr. Lee, come to the room. She's not doing well.
An hour later.
Yeah, about an hour later.
Okay.
So I go to the room, and this is what I see. She's totally different.
Stridorous.
She's obtunded, she's glassy-eyed, she's not answering my question any longer. If you remember, she was a chatty lady,
Yeah.
right? Very pleasant, chatty lady. She was sitting up and stridorous. She's tripoding.
I'm regretting not examining the pharynx.
So she's tripoding. She's not drooling, fortunately. Her SATs with an SVN that the respiratory tech already got started on her is low in the 90s, okay? She was given morphine about 30 minutes before this, so I'm thinking, okay, well, maybe it's just maybe a little too much morphine for this lady.
I'm really worried about the throat once you say stridorous.
Yeah. So I'm in the room. I'm worried now.
Yeah.
Next step, let's see. Maybe it's just a COPD that's undiagnosed, asthma. I put BiPAP on her. Her SATs are not getting any better, right? The husband is at the bedside. He doesn't look that worried, honestly. He goes, well, this has happened to her before, and she comes out of it. He said that she'll get a little confused or something. She'll like grab at things in the air, but then she comes out of it. Yeah.
That worries me even more. It's just not right.
I told you there was a little surprise in this one.
Yeah, every single one. On her pharynx exam, was there any swelling? Could you see anything?
I didn't look at her throat.
No.
I didn't look in her throat.
Yeah. Yeah, you're focused on the chief complaint, which is the abdominal pain. You wanted to know what was going on with the abdominal pain.
Yeah.
And she's focused on that too until you have this impending airway doom.
All right, so I'm at the bedside. I'm sweating a little bit.
Yeah.
Okay, so we tried the epinephrine racemic.
Stridorous, morbidly obese people are not easy to intubate.
Right. So I had tried the BiPAP. It didn't really make her like turn around or anything. So I threw in a little racemic epinephrine. I just was at the bedside getting more and more nervous about it, and I thought, well, let's just take a peek in there. Okay, she's been hoarse for 6 months, and she's hypoxic. She's now obtunded. Let's take a look. So my go-to, I always use ketamine. I love ketamine when in these kind of situations, right? So I give her a little ketamine. I look in there. It was really unrecognizable. I did not see an epiglottis. I didn't see any tonsils. And during this quick peek, which usually it's a very stable situation, she crashed. She became really hypoxic.
Pro tip, and I'm going to pat you on the back. You gave her ketamine, but not paralytics.
No, you cannot do that in a situation like this.
We all get used to doing RSI.
Yeah.
And unless we stop to think about it, can I actually ventilate this patient once they're paralyzed, you can have an airway disaster.
Exactly. So ketamine is the perfect agent for these kind of airways where you are just not sure, you are a little bit nervous, you do not want them to stop breathing. I am a guest teacher, instructor over at the U of A Medical School in Phoenix, so I was there just the other day, and my little lab was to teach the students how to intubate.
Yeah.
And so part of that discussion during that those little sessions was to talk about different induction agents, one of which is the ketamine. So I talked a lot about ketamine, and I was showing them some cases and all.
So you couldn't recognize any anatomy at all?
I was. Oh my gosh, what was in there?
Swelling? Was it redness?
So it was
tumor?
warty looking. It was
Warty.
white, a little bit of blood-tinged saliva in the back of the throat. I used a glide scope because I knew that this was a difficult airway. Her soft tissues posteriorly were just completely unrecognizable. They were pale, and you can just imagine the laryngoscope going and kind of sliding across this white, unrecognizable soft tissue in her throat, right? There's a little bit of blood on the posterior pharynx. There's no vomitus. She's not coughing any phlegm. She doesn't have any phlegm. There was nothing that I could identify reliably as vocal cords. The classic white, two white cords, right? Which I jokingly was trying to teach the students yesterday. It's Sauron's eye.
Yeah.
Oh, Sauron's eye in Lord of the Rings.
The way you're describing it, makes me a little nervous, a little sweaty right now. Just imagining that you're about this close to a crike.
Yeah. So it was unexpectedly alarming, I guess.
Yeah.
You put that blade in there, and you expect to kind of see some recognizable structures. The only thing I recognized was her tongue.
Wow.
Right. So, going back to what I described, there was nothing that looked like the vocal cords or even an epiglottis. Okay, nothing that looked like that. Okay, so the anterior part of the tongue looked normal. The base of the tongue was covered because I had the blade on it. Nothing recognizable in there, right? And during that quick peek, where I'm like going, "Oh, MG, what is in here?" Her SATs plummeted.
Yes.
So I had to intubate this woman, right?
Yes. You passed a tube blindly.
Essentially. I kept looking around, and you just have to ignore the frantic cries from the respiratory techs. SATs are dropping. There are 70. There are 60. The nurses and the techs, they like to update you.
Yeah.
Maybe it's their way of calming themselves down, but it just doesn't help me. They keep telling me the SATs dropping, right? Anyway, regardless, ignoring all that, I'm looking around. Thank God there was no vomitus in them. Looking around, and finally I see this little tiny area that was a little bit pink and looked a little bit like
maybe a little bubble in saliva.
Maybe a little something. I just went for it.
Yeah.
And it was a small tube because I anticipated it'd be a difficult airway, and by the grace of God, I got it. So, there's a little bit of a surprise, huh? Somebody
Yes.
comes in with abdominal pain. I was able to take a peek back on her. She really looked good afterwards. She stabilized. She was interactive, believe it or not, after being intubated. She was arousable. I always restrain people if I think they have a chance of pulling out a difficult airway.
Oh, yeah.
Yeah. She was able to open her eyes. Mm-hmm. She woke up, she opened her eyes, and she was nodding what seemed like to be appropriate when I was asking her questions or talking to her. And that makes sense because this was not a prolonged period of hypoxic. It was an obstruction, right? It was an upper airway obstruction, as if she aspirated, let's say, a piece of grape down her trachea. And it was brief and it was taken out. And it's...
Yeah, like mucus plug.
Right.
Yeah.
So it makes sense over how she was afterwards. So in the meantime...
Yeah.
Yeah. In the meantime, I've completely forgot about the abdominal pain, no CT abdomen, nothing. I just sent her away to where there's ENT.
Oh, I mean, she needs that removed. And, I mean, you can get a CT of the neck, but it's going to tell you there's a mass in there, which you saw already, that's obstructing her airway.
Well, I saw not a discrete mass per se, but I just saw very unrecognizable landmarks, just sort of soft, floaty, soft tissue. And I didn't really see any specific solid mass.
And you got ENT to accept?
Yeah, shockingly, right? All right, so obviously, very interesting case. Big surprise in the middle of it, of an abdominal pain workup. She's out of there. I'm finishing my shift. I'm going to have to look her up. This is a lady who will have to follow up what happened, right?
I mean, you can attribute the hypoxia to the upper airway, but she wasn't stridor. She was just hoarse. She's a little tachypnic. She's a little tachycardic, right? But she's had that hoarse voice for 6 months since the surgery.
Yeah, exactly. Chronic, you just don't pay a lot of attention to that.
Could that be phlegmon?
Who knows, right?
Yeah.
We have a question. You have a question. Why? Yeah. Why was she like that? And when I looked in the throat, there was nothing specifically recognizable as a mass or a tumor that I could say, oh, that's been growing for 6 months, right? So it was just totally unrecognizable.
Going back to sort of the clinician approach versus sort of how we get taught, I guess I put it this way. Most of medicine is pattern recognition, works about 85% of the time. And some of the differentials that we threw out are just that, pattern recognition. Stuff I've seen before, stuff that could do this, stuff that fits the story. About 85, maybe 90 if you're lucky, maybe 80 if you're not. Roughly around that period of time, pattern recognition will work. but sometimes it won't. And when it doesn't, you become this detective. Where you can assume nothing, trust no one.
Yes.
You literally have to go back and go from point to point, make a list in the differential, and just kind of knock them off one by one. Very painful to do in a busy ER shift where you're getting interrupted a lot of times.
Right. I looked at her chart afterwards, and they did do a CT scan the next day, and what it showed was there was diffuse laryngeal and pharyngeal edema with asymmetric swelling to the left at the supraglottic area with hypodensity. So then ENT took her to the OR, and this is the OR report.
Wow.
Correlates with my experience.
Yes.
There's no discernible landmarks.
Yeah, if you take a look in somebody's throat and then go, oh my goodness, not good.
Yeah,
like,
but
where am I?
Yeah, right. He wrote that, and he saw that there was a diffuse exophytic mass on the left, more so than on the right. It was basically cancer.
Yeah.
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 All right. So for each of these episodes, I would like to leave us with, 2 learning focuses. First one and this one will be ER doctors. We have got to be the master at obtaining an emergent airway.
I've always felt that you graduate medical school with an MD or a DO, and you can call yourself doctor, but you don't really become one until somebody dies. And the first patient that ever died on me was an airway disaster.
Oh, gosh.
The second patient I remember losing was a trauma airway disaster. And it's really difficult to kind of look back and think, what if?
Yep, exactly.
The airway skills are rote, routine, and boring once you get to trust them until it's a disaster, and then nothing goes according to plan. You have to be able to have a backup method of intubation. You have to have a difficult intubation to be able to face that. You have to know some tricks, lay of the land, bump for the obese people, on and on.
Can you think of a case that you want to share about a difficult airway that you've had?
Yeah, actually, it was one I'm quite proud of.
Good.
It was here at Baywood. There was a code blue called in the CT scanner. It was a patient from the ICU that came down for a CT. She was on BiPAP. She was morbidly obese, 350, 400 pounds. In the midst of ongoing CPR, I was able to get a glide scope in. She was incredibly anterior.
Yeah.
But maybe it was just her good luck or my good luck or both.
Yeah.
But I was able to immediately see the cords and pop it in. But just walking into the room to see a 350, 400 pound woman with no neck and a small mouth beating CPR to try and intubate
so nervous.
Yeah. I'm not ashamed to say that I yelled out loud when I got it. But
it's one of those cases you high five everybody in the room, right?
Yes.
Yeah.
So we did laryngoscope. I mean, we did a glide scope for her, but in prep, I had a backup tube and I had a backup blade, and we just went for it because it was a code. No sedation, no paralytics. And I just went ahead and went for it as a code. Luckily, we were able to get her back.
Have you ever criked anybody?
I have never successfully criked anybody.
Okay. So I've criked 2 patients in my 24-and-a-half-year career. Fortunately, both times successfully.
Yeah.
The first one was probably 15 years ago, and then the second one was just about 3 or 4 years ago. And in fact, it was such an amazing case that I wrote it up, and it was published on Emergency Medicine News. Such a remarkable case. So if anybody's interested in looking at that, it's just something to look up on EMN. But I have intubated lots and lots of patients in my career, and I have been very proud of the fact that I'm great at it. And I think that emergency physicians have got to be, hands down, the best one at obtaining an emergent airway.
I think
that would be lesson number 1 in this case, where it totally illustrates it, because she comes in with ostensibly the chief complaint of abdominal pain.
Right.
But you and I were like, okay, there's a little something else going on. We're not sure what it is, but let's just proceed.
Can we talk about the relationship where the husband goes, yeah, she does that?
That is funny. All right. Then the lesson number 2 on this particular patient I'd like us to focus on would be ketamine. Have I said ketamine a few times? I have used ketamine in innumerable situations in my career. For instance, in this lady in the episode, I used ketamine to peek at her, but usually when I use it is when I anticipate a difficult airway and I do not want the patient to stop breathing, because the natural reflex to improve your oxygenation is something you can't take away. You should not risk taking away. You can't do better than that.
Right.
Okay. I had a recent patient that had a thermal inhalation burn to his throat. I used the ketamine for that. I've had a patient come in with aspiration of a piece of food in her throat and stridors. I had a guy come in with a bee sting in his throat, and I used the ketamine to take a peek.
So you like it for the dissociative effect without the sedation?
Correct.
Okay.
Yeah, they're out. They're not going to fight you. They may move a little bit, but they're out, and you can go in there smoothly, gently, and just take a look in the back of their throat. And like I said, in these cases I just talked about, they all were successful in that I was able to take a look and make that final decision. Am I going to intubate this patient, or what is going on? So I have lay of the land, like you said, So that's what I really want us to take away from.
Do you use ketamine for other procedures, hip reductions, any type of orthopedic reductions?
I use ketamine for procedural sedation. It was used very commonly in children. It was studied in children. And so I did use ketamine mostly on children initially with different procedures for them. But I definitely have used it more and more in adults. With procedural sedation, I tend to use more the propofol than the ketamine. But the ketamine is still a great drug in those situations.
I've used my fair share of propofol, but I'll try starting using ketamine on adults a little more.
Right.
I was always wary of it because the emergent reaction that's supposed to happen.
Right, and that's more, I think, in my experience, more noticeable in the children, and that's because they're children. They don't know how to respond to that kind of weirdness and nightmares, perhaps. In adults, I think that adults are still are able to kind of control their reaction to, let's say, weirdness or nightmares. So I haven't had that much bad reemergence phenomena.
Or apparently your wife getting periodically hypoxic.
Well, that's the case. Thank you, Dr. Vasquez, for joining me on this episode. And thanks, everyone, for listening and watching. I will see you guys later. Bye.
Bye.